But coming back to this, and I'm just so privileged today to host a panel of experts behind me who have come to talk about a topic that we hardly ever talk about: caring for the care workers. Most of the time, we focus on the patient, and rightfully so. There's nothing wrong with focusing on the patient. But health service delivery is supported by healthcare workers. And who supports the supporters? Who cares about the men and women who leave their families and homes behind to go and care for people who are most of the time destitute, helpless, in need of not just physical care, but emotional care, psychosocial, all aspects of care. And these people come out and they provide this care on a day-to-day basis. Let me introduce you to the first speaker. So the first speaker is Tendai Mafuma. Tendai is a legal researcher on the public health team at Section 27, a public interest law organization that advocates for the right to quality and accessible health care services for all South Africans. She holds an MSc Biochemistry and LLB degrees from the Rhodes University. After university, she spent a year as a law researcher for a Justice of the Constitutional Court in South Africa. Tendai has been at Section 27 for 2 years, where she has been involved in matters regarding mental health, access to medicine, sexual and reproductive health rights, and community healthcare workers. So welcome, Tendai. Thank you.
Thank you so much for that, Gloria, and thank you to everyone for being here. Hopefully my presentation is going to be interesting. I know it's after lunch, so sometimes we go into a little bit of a slump. But I'm going to talk about community healthcare workers. And I was quite excited when Gloria was giving her a background as a healthcare provider, because she started at nurse, right? How many of you here have ever had to interact with a community healthcare worker? If anyone can put their hand. How many of you have had to receive healthcare services from a community healthcare worker? One hand, right. So for most of us, when we think about getting healthcare services, we start at the clinic level. We start at going to the nurses. This is not the reality for a lot of South Africans who live in pretty much all of South Africa. Their first point of contact with the healthcare service, healthcare is with a community healthcare worker. And these are basically the people who live in their communities and who have dedicated their entire lives to just serving the communities, walking from door to door, talking to them about their healthcare needs, sometimes collecting their medicines from clinics to bring them to them, educating them about various health issues, right? So that is the first point of contact with health services for a lot of people in South Africa. So I've got here on my slide just a definition of what community healthcare workers are. They perform various tasks, from visiting and assisting frail people in their homes, educating about HIV and TB, and also sexual and reproductive health rights, and so much more. At this stage, there are about 70,000 community healthcare workers in the country. If it was a Department of Health official speaking, they would say there are about 96,000 community healthcare workers in the country. Every year, there's an audit to see how many community healthcare workers we have in our database. Every year, we never get results of that audit. So no one knows how many community healthcare workers are there. Whilst a lot of our policies, a lot of our healthcare policies have accepted and acknowledged the importance of community healthcare workers, very little has been done to integrate them into healthcare services. Very little has been done to recognize the work that they do and how important it is. So there's a lot of big talk in our policies, right, about how community healthcare workers are so important for primary healthcare services, how they were so useful, how they were so helpful for the HIV and TB response, making sure that people adhere to their treatment, leading adherence clubs. But when it comes down to taking care of community healthcare workers, there isn't much action there.
So my next speaker is Professor Laurel Baldwin-Ragaven. Laurel is a physical educator, scholar, and human rights advocate. Laurel is a professor of family medicine at University of the Witwatersrand. She's the clinical head of the Department for Gauteng Family Medicine, a combined service training platform providing comprehensive primary health care to the population of 9 million people. Laurel conducts research and writes extensively on dual loyalty of healthcare workers, medical participation in torture, health sector complicity with apartheid state violence, gender-based violence, feminism and bioethics, migrant health, and training and education in health and human rights. She's the fellow of the Canadian College of Family Physicians and the South African College of Family Physicians. Thank you very much, Laurel. Over to you.
I was given the task of talking about care as work for health professionals. And so as a physician, it's very hard for me to third person that because I went through this training, albeit not in South Africa, albeit in a very different generation from most of you in this audience. And I thought that I would share that with you and kind of position myself with regard to work as care, at least how I've experienced it over the past 40 years. So I started McGill University in August of 1979. So that is 40 years ago. And I had a degree before that in what was called American Studies. It was the first interdisciplinary degree practically anywhere in the world. And I happened to focus and concentrate on sociology as well as in literature. So that was my background going into medicine. I did not get into medical school, obviously, the first time around, even though I had done all of my undergraduate preclinical subjects like physics, chemistry, biology. I even did electron microscopy, but it was not recognized when I was applying to medical school in 1977. So I then went to work at NIH in Boston in genetics and biochemistry in a laboratory, and out of the 4 medical schools that accepted me the second time around, for reasons which may become apparent a little later, I decided to go to McGill. Now, McGill Medical School is in Montreal, in Canada. It has a national health system, not an NHI like here. So you basically can get most things that you need. Let me just leave it at that for now. There's a single payer, there's no insurance companies. If you have medical aid, it augments. If you want a private room, a private attendant, that's what the healthcare system does. And I think it's important to put up the logo there because everybody's into logos. And this one actually says that everything grows with labor, with work. Okay, that's the McGill, and the 3 martlets, those are those little birds. And in domino confido, which means I trust in God, in the Lord.
Thank you very much, Laurel. This presentation hit home for me. As you were speaking, I was reliving my experiences as a healthcare worker and reliving the trauma that I've been exposed to, being a young medical student working at the surgical pit at Baragwanath Hospital, and the horrors that we've seen there. And for you to cope, you get told, close here, open there. And perhaps we have such a broken health system because people who are providing the service have closed here and opened here. Right? Thank you very much, Laurel. Right. So, with that, I'd like to introduce the third speaker. So, the third speaker is Leanne, all the way from Cape Town. Huh? So, Leanne is a public sector doctor, like myself, who's turned into a health policy and systems researcher. She's a public servant and currently works as an embedded researcher in the Department of Emergency Medical Services and the Health Policy and Systems divisions at UCT. She works with a range of art-based methods such as documentary film, photography, and poetry to better understand and engage with the complex social issues that impact the health system. She's currently a PhD candidate focusing on collective action in response to violence in the health system, and is focused on the role of the health system in society and how the health system itself can be a mechanism to build a social solidarity and reduce inequality. Over to you, Leanne.
Hey. So I'm actually going to be showing you a film, but before I do that, I just want to give a little bit of framing for the work so that where it comes from makes sense. The work I'm doing at the moment is situated in the Western Cape, but I think it's also just important to reflect that emergency medical services across the country are in crisis, and the challenges faced in the Eastern Cape or Limpopo, where I used to live and work, are very different to what we see in the Western Cape itself, which is a relatively well-resourced system, and in terms of delivering emergency care, one of the major challenges it faces right now is that of violence. So I think many of you will have seen these kinds of things on the news. Paramedics really are negotiating unacceptably high levels of violence every day as they try to deliver care. There was a horrific incident just this weekend. There's all kinds of data and statistics on these things, although I don't think the numbers help us very much, to be often. But what I will say is there's an alert system that comes to me and others, and every couple of days there's an incident. And it's a very small community of people, and so you can imagine the ripple effects of hearing about what happened to one of your colleagues and an attack kind of once or twice every single week. I guess one of the other things I want to raise during this session is the interconnectedness of the kinds of violence we can see, so direct attacks on paramedics and other things, and some of the violence that's less difficult to see, so different forms of structural violence. One of the things that the department has done is to introduce something known as red zone policy. Some of you may have heard of it, but for those who haven't, basically there are certain parts of the city that have been declared too unsafe for paramedics to go into without police escorts. And so in those parts of the city, paramedics need to take South African police services with them. So as you can imagine, although this is the best solution, was the best solution at the time, it's really not a great solution. It's intended to protect paramedics, but it does nothing to address any of the underlying structural factors that perpetuate violence, and it also doesn't make sense to paramedics at all. So many paramedics live and work in the same neighborhood. So it's not, I guess with a lot of healthcare workers, you often work in a neighborhood that's not the same street you grew up on. That's not the same for paramedics. I actually think of paramedics as the community health workers of emergency care. So it's a very complex thing to make sense of, because effectively there's a policy where you're being told to wait outside a police station so you can have a police escort to go to your neighbor's house to collect her. And in some instances, patients die before paramedics get there because there aren't enough police to go around either. I think it's also really important to reflect on both the historical legacy that has put in place the conditions for this violence, but also the current injustice. So I guess also a number of people in this room will have seen the report of resource allocation of police resources that the Social Justice Coalition put out a couple of months ago, demonstrating that the way we allocate resources today actually isn't very different to the way it was done during apartheid. So people always ask, why are paramedics specifically being targeted? Is it a case of paramedics being caught in the crossfire in an increasingly violent society? Is it a bit of both? I think Nolwazi brought up today this idea of different ways of knowing, and I think that's something that's really important for the health system to take account of, that there are multiple competing legitimate perspectives on what's happening on an issue. And so it's probably a bit of both and also includes many other factors. I think it's also important to recognize that violence is a very complex social phenomena, and so some of the ways in which we have been approaching it thus far, using primarily public health approaches, are quite inadequate. As I said earlier, very much rooted in our history, so histories of colonialism and of apartheid specifically, and that much of those patterns of violence are still in place today. And of course, these are interconnected.
Thank you, Leanne. So hands up if you received the services from an emergency practitioner in the past month. I have. I was with my son in the back of an ambulance a week ago. And they are amazing. And these are the people who leave their homes and they go literally into a war-torn country. South Africa, let's face it, there are some areas that are like war zones. And they go in there with a faith that they will come out. So Anyway, let's introduce our last speaker. Last but not least. Our last speaker is Job Zwane. Job is a PhD student in the Department of Anthropology and a Think Fellow in the Humanities Graduate Center at the University of the Witwatersrand. He has previously interned and worked at the Wits History Workshop. His presentation is derived from his master's dissertation titled Popular Fear and Distrust of a Hospital Dubbed Slapgaal? Huh? Yeah. Slagpaal. An ethnography of gossip and rumor in former Kwandebele, South Africa, submitted at the University of Pretoria's Department of Anthropology and Archaeology in 2018. The stage is yours, Job. Thank you.
Good afternoon. So the talk is derived from my master's dissertation. And I actually wanted to change that title because it's quite awkward, but it was too late, and you know, a lot of paperwork that needed to be done before it could be changed. But Slagpaal is Afrikaans for slaughterhouse, so that's what the people have dubbed or nicknamed the hospital. So there's a number of names that they use. So it's Slagpaal, or the English version of that, butchery, or some would say it's a mortuary, and so forth. Okay, I think I'm gonna use okay, so the disclaimer that I have is that I did not look at the voice from within the hospital. So I did not interview any staff, the nurses, doctors, etc. I only mainly focus on the community perception of the hospital, and the reason for that was that in the earliest stages of the research, I actually wanted to represent the voices from inside. It would have been very interesting, but it was very difficult to get access. As you can imagine, the management is quite suspicious, and I ended up just giving up on that, so I only focused on the perceptions from the ground. So I recorded daily conversation in taverns, in minibus taxis, basically chance encounters, patco buses, and followed social media exchanges on Facebook and WhatsApp. I also connected semi-structured interviews with former patients, family members of patients and relatives, and other people who did not necessarily use the hospital. So I forgot to mention that the presentation is divided into 3 parts. The first part will just focus on the history, the general history of distrust of biomedical technologies and biomedical practitioners. And let me just say that you will see later on if I get to the end, because the slides there's quite a lot of them and they're very detailed. But if I get to the end, you will see that the distrust is mainly about medical practitioners rather than biomedicine as a model. And so the second part focuses specifically on nurses, the distrust of nurses, and just to look at the historical roots of that distrust. And then the final part is roughly tries to answer or to look at the cultural logic that informs this distrust. Okay. So I'll look at examples in colonial health services and in the post-apartheid period. You will see that actually in both periods, this distrust has racial undertones, but in the post-apartheid period, it's mainly a distrust of the West, so Western pharmaceuticals.